Sir, good evening, sir.
You are not visible.
Sir, good evening, sir.
You are not visible. Now you are visible. మేము మంచి హుషారుగా తిరిగేస్తున్నారు. మంచి హుషారుగా తిరిగేస్తున్నారు అంటున్నాను. ఇది చైర్పర్సన్ ఎవరు మీరు ఇంట్రొడ్యూస్ చేస్తారు కదండి, చైర్పర్సన్ని చైర్పర్సన్ని మీరు ఇంట్రొడ్యూస్ చేస్తారా? Hi, good evening, Dr. Subramanya. Good evening, good evening.
Good evening, sir.
Sir, good evening, sir. Subramaniam, sir.
Good evening, sir.
Dr. Ramesh Bajaria, good evening.
Good evening, sir.
Sir,
Ramkrishna, sir, good evening.
IAP State platform. I did not invite Subramanya because he is part of IAP State.
Oh,
That's why I did not invite him, even though he is speaker. Previously, he is part of IAP State previously emotionally, now physically also. Am I right? Physically also, Dr. Subramanya. Right.
I'll just share my screen and see.
Yes.
okay, sir.
Yes, Subbu.
Yes.
Good evening.
Good evening, good evening. Is it fine?
You are expert. You need not try even, Dr. Subramanya.
Yes, sir. Yes, sir.
Yeah.
Okay. Now I am comfortable. But the slides should move, that's all.
Dr. Bajaria, Ramesh, how are you? Everything is fine?
Yes, sir. Reached safely. And once again, back to square one with clinic.
What's there? You are a
He's
gentleman. You are a gentleman. You
No, no, he's
Thank you,
not
sir.
gentleman. He's a rich man from rich state.
also that part I don't know. I know he's very influential.
No, I meant enrich, environmentally rich.
Yeah, environment rich, I know. Championing the cause of environment. Yeah. Okay. Right, okay, right.
That's Kiriti, yeah?
Yes, sir. Yes, sir. Good evening, sir.
I'm able to recognize you in that shadow moving. That's
Yes, sir.
Because,
I'm
oh, Subramanya,
You are
both of you are neighbors now. Now you
I
are
was trying
neighbors.
to see that puzzle. Who is it?
yes, sir. I am on travel, sir. I am on travel, sir.
Okay.
Yes, sir.
Subramanya,
Hmm.
both of you are neighbors now.
Yeah, yeah.
Ah. Kiriti will be coming to your college for inspection, university inspection.
Oh, yes, yes.
Hmm. And Dr. Subramanya and Dr. Ramesh, Dr. Vijay Kumar is joining in just 2 minutes. Okay.
Okay.
No, no problem. I'll introduce him, sir, whenever you say.
Right.
Tomorrow I'm going to Nagpur, sir.
Nagpur. Right.
You started that journey, remember long back, I think 12 years back.
Capital. What to capital? X not.
GI.
Double L. Y at the rate 1, 2, 3.
Dr. Vijay Kumar joined. Okay. Dr. Kiriti. Sure, right. Welcome, Dr. Vijay Kumar. Welcome.
Yes, sir.
Unmute. Dr. Vijay.
Sir, good afternoon.
Yeah,
Sir,
good evening.
Come, sir.
good evening, sir.
Right.
Good afternoon. Good evening, Vijay Kumar. Good evening,
Vijay
sir.
Kumar, sir. Good evening, sir.
Good evening, sir. Good evening, sir.
Vijay Kumar, sir. Good evening.
Good evening, sir. Kiriti, sir. Good evening.
Good evening, sir.
Sir.
Dr. Ramesh Kumar, he
Sir.
is our chairperson is Dr. Ramesh Bajania from Gujarat.
Yes, sir. Yes, sir.
Right. He's a nice gentleman.
We were together, no, sir, in EB.
Ah,
Yes,
yes. You know,
Last year.
of course. I need not tell you. Right,
Yes.
right. We were together.
Yes.
Dr. Kiriti, shall we start?
Yes, sir. Yes, sir. We can start, sir.
Right.
So, welcome all to the IAP on behalf of IAP AP State Chapter. Welcome to you all to this on this platform of academics IAP State. I heartily welcome Dr. Subramania sir, Dr. Ramesh sir, and Dr. And our president M. Suresh Babu sir is on travel now, and I welcome our central IAP member Dr. Ramkrishna Moram sir, Dr. Vobal Reddy, Dr. Pawan Kalyan. And a warm welcome to Dr. Vijay Kumar sir, from Warangal. Though he is in Telangana, he is a close associate with Andhra people, sir. We feel as if he is our state person, sir. Am I audible?
Yes, very much.
Sir. So about Ramkrishna Moramsa, sir. Hello, sir.
Yes.
Shall I introduce Ramesh sir, sir?
Yes. Please introduce.
Yes, sir. 1 minute. Sir, Dr. Ramesh Bajania, sir, is a diplomat in environment and child health. And he's a member planning area committee, environment, health and climate change international
That Kiriti got muted.
Is a
He got
chairperson
muted.
environment and child health.
Okay. Shall I go through? That Kiriti, you are getting muted. Okay, I will introduce Dr. Kiriti.
Ramkrishna sir, you may please.
Right. Kiriti, I will do it.
Okay, sir. Yes.
Welcome today's chairperson, Dr. Ramesh Bajania. He is from Gujarat. He is a diplomat in environment and child health of International Pediatric Association. He is member planning area committee, environment, health and climate change, International Pediatric Association from 2023 to 2025. He is the chairperson for environment and child health group 2021 to 2023. He is very actively taking forward the environment child health group, and he is going to make it as a subchapter of IAP. And he is secretary for the environment and child health group of Central IAP from 2019 to 21. He had been the executive board member of CIAP in 2022 and 2023. He is member of IPA, that is International Pediatric Association, SAG, that is Strategic Advisory Group on Environmental Health, 2021 to 2023. He is the convener and coordinator, faculty and workshop on environment and child health, IPA, that occurred in Gandhinagar, that is in Pedican 23. He is the organizing chairperson for Prevention Fedivision 2016, 2021 and 23 ECHG annual conference. He is the organizing secretary, Gujarat Pedican 2010. He is participant roundtable on lead poisoning, New Delhi 2023. He is a member of Indian Action Group on lead poisoning. He is coordinator of West Zone Presidential Action Plan of CIAP, Good Practice Module, CIAP and SSS. And he is member of National Advisory Board, IP Care, Journal of CIAP. He is National Trainer Module for CoWIN, ODAI, Point, NTEP, NCECD, and UMP. Above all these, his achievements and being environment friendly and for child health rights, he is a very nice gentleman and is very friendly. It's our privilege, Dr. Ramesh Bajania, to invite and chair the session today. Thank you for joining and please take over. Please take over, sir. Unmute. Dr. Ramesh,
Today's faculty, Dr. G. Vijay Kumar. He is MD DCH fellow of Central IAP. He was my colleague as a EB member in 2022. He's a vice principal at Kakatiya Medical College, Warangal, and excellent human being, good teacher and academician. I'm very sure that our colleagues will enjoy his vast experience and knowledge. He's an S academician. Over to Dr. G. Vijay Kumar.
Thank you very much, sir. Ramakrishna, sir. A few days back, you have invited me to this digital platform, and I knew that Dr. N.K. Subramanian sir is going to speak on the topic. And sir, how shall we go, sir? Shall I introduce the topic right now? And
First Dr. Subramania and then the topic.
okay, sir. Dr. Subramania sir doesn't require any introduction, sir. Sir has been very active throughout the country, and he has been in Karnataka in Vaidehi Medical College, then he is into PS Medical College now. Sir, in IAP respiratory chapter, sir has actually revolutionized the way we see at patients, and during conferences, whenever sir takes a lecture, the hall is totally full. Sir has he has widely traveled in the entire country, including he has come to my college, and he has taught the postgraduates and IAP Warangal also. So thank you, sir. After some few months gap, I am seeing you again, sir.
Adding to what Dr. Vijay Kumar has told, Dr. Subramania was Vice President, South Zone, Central IAP. He was the President, IAP, AP Respiratory Chapter 2022. He is a wonderful teacher. He's very good at pulmonology, especially reading the chest X-rays, and he's very active. And it's a privilege for IAP, AP, that he is physically now in Andhra Pradesh. Now he's medical superintendent in Kuppam Medical College, PS Medical College, Kuppam. And we invite Dr. Subramania to enlighten us. Dr. Vijay Kumar, regarding the subject, please introduce.
Yes, sir. Again, Subramania sir makes his presentation very interesting from the title itself. The title sir has given is Amoxicillin in Respiratory Practice. Amoxicillin, I thought our generation, we have prescribed liters and liters of amoxicillin, and some young colleagues, probably they do not know whether amoxicillin solo is available. They know amoxiclav, and there are many more clavs other than with amoxicillin. I think sir will definitely touch upon this topic, because that's the reason why sir has selected this amoxicillin one, because amoxicillin is a very different antibacterial from amoxiclav. One thing is that, and sir also said respiratory practice. He did not say respiratory infections. Right now in Telangana and in my department, sir, a viral respiratory epidemic is going on. And actually, after the VRDL labs have established, now a specific viral diagnosis, which we thought 7-10 years in say relatively peripheral places like Warangal, not very remote place, but not really a metro. That way, the VRLDL labs and government sector have changed totally the way we think about viral infections. So in the present viral epidemic that is going on everywhere, the older children and adults who are suffering from dengue fever, and then there is under 5, there is a respiratory epidemic as such going on. And in the last 2 weeks, of the 21 samples that are sent to the VRD lab, they have given the reports from Warangal. It is of the 21 samples, 6 were negative for any virus, and 12 of 15 positives were RSV, and then 3 others were influenza. So, if we are talking about a viral respiratory infection specifically, it at least the minimum thing that is that beneficial is that there is some antibiotic stewardship that can happen. So, and then again, it's a referral center. When we know that a predominant viral epidemic is going on, and the pattern of antibiotics that are given, it's quite difficult to understand. And I think that one place also definitely sir will touch. And he also said respiratory practice. He did not say respiratory infection. Probably sir will touch it in 3 ways. In a non-infection, how to avoid an antibiotic at all totally. If at all to use antibiotic in a gray area, how to use it. And probably sir will say about upper respiratory tract infections and lower respiratory infections, both outpatients, inpatients. Actually, I am waiting for this lecture, sir, because right now whether there is a place to give a steroid, probably if there are questions, which place it is safer to use a steroid, or steroid is beneficial, and where a steroid is probably detrimental. These are some, I thought this would be the plan of sir's lecture today. I invite Dr. Subramania NK sir to speak on amoxicillin in respiratory practice. Over to you, Subramania sir.
Sir, first of all, thank you very much, Vijay Kumar sir, for not only giving the lead for the today's discussion, but also being a very good friend of mine in my life and a mentor and a teacher of many of his students are there as my colleagues are. Thank you very much for being part of us in our life. Dr. Bajania, who has been a very good friend of mine and an environmentalist, is a close associate with the respiratory team as well from the land of Gujarat. And Bajania, thank you for being such a nice, wonderful person in my life. You know, very rarely we have some persons in our life. And Dr. Kirti, I don't think, may God bless you forever for, you know, not only cherishing academics, but also seeing that everybody visits Lord Venkatesha whenever we visit Kirti. And even he took my parents to the temple. For life, we will remember you, Kirti. Very nice conference that we had in AP. Dr. Ramakrishna sir, the tall leader, the most wanted teacher, and he is the EB member, has occupied various posts in AP and has been in the forefront in many teaching platforms. I think he is the most popular figure now in that you would see in teaching platforms. And he has also been very dedicated teacher, and there are Wednesdays that I miss, but there is not even a single day that he has missed. So that's the commitment to the students, and most of the students are lucky. But for the formalities, today's talk is on amoxicillin. Dr. Vijay Kumar, let me promise you that we'll cover all those queries that you have addressed, and most probably my slides will make justice to all the queries that you have told. Indications, how to use mox or amoxiclav, what about viral infections and role of steroids, stewardship, everything I will cover as much as possible. And may I take you through around 20-25 minutes of discussion, and probably we'll have more question and answers that would clear many doubts in the minds of the practitioners. Amoxicillin looks a simple molecule, but it's not as simple as we think in practice. Now, let me take the presentation in the following format. Some basic pharmacology, because it is forgotten for most of us. We are very busy in prescribing, but we have not revisited our basics. Only few slides I'll take, but they are very important because the way you practice depends on the way you have understood the drug. Some indications, some uses, some adverse drug reactions, some conclusions, including preparations and dosage. Let's visit the basics. Actually, penicillins are of two types: natural and synthetic or semi-synthetic. The natural penicillin cannot be taken orally because it is acid labile and is destroyed in the gastric pH. However, we can have acid resistant penicillin, which is available as Pentid, I think popular prescription, and it's oral penicillin, penicillin B. But we have semi-synthetic penicillins that would overcome all these problems of the natural penicillin. They are either penicillinase resistant, beta-lactamase inhibitors, or some of them are extended spectrum penicillins. This is just to give you an overview, do not worry about it. And extended spectrum means most of the penicillins cover gram positive, but extended spectrum means they also cover good number of gram negative, and does not include Pseudomonas and others. While penicillin is very good for anaerobes, the semi-synthetic penicillins are good for aerobic coverage and some gram-negative coverage also. These extended spectrum penicillins will include aminopenicillins, carboxypenicillins, and uridopenicillin. And aminopenicillin means they have an amino group, and that's why it's called as amoxicillin, aminopenicillin. and ampicillin. So am comes there only because we are dealing with aminopenicillin. So basically, extended spectrum will have some group in the substitution. If it is amino, it is called as ampicillin or amoxicillin. If it is carboxy group, then it is called as carbenicillin and uridopenicillin, like piperacillin, which you are very much familiar with. Now, let me just take you through structure of penicillin, but not very much required. Do not worry about the complexity of the slide, but all that you need to understand is amoxicillin is called aminopenicillin because it has an amino group, while ampicillin also has amino group. But the difference between the two is that ampicillin is long acting and amoxicillin is short acting and better bioavailability. But only thing is that amoxicillin has to be given 3 times a day ideally, but while ampicillin can be given less frequently. So this is just an overview of what I was talking to you. But apart from extended spectrum penicillins like ampicillin, amoxicillin, we have also got beta lactamase inhibitors that will add, we will add to this extended spectrum penicillins like clavinic acid, sulbactam and tazobactam, and I'm going to touch them because they are very much widely available commercially. Clavinic acid is very popular with amoxicillin, sulbactam with ampicillin, and tazobactam with carbenicillin. Of the three, tazobactam has independent actions against Acinetobacter. So that's what is important for you to understand, apart from being in combination. Now let's just look at mechanism of action. Penicillins actually prevent the synthesis of cell wall and they destroy. And how does that work? There is a peptidoglycan layer. You just focus on that brown layer, which is there in most gram-positive and gram-negative organisms. The difference between gram-positive and gram-negative is the peptidoglycan layer, which is the core of the cell wall, is present in the outer wall in the gram-positive organisms. So when it is not synthesized, there is destruction of the outer layer of the cell wall, and therefore there is autolysis of the cells. Whereas in gram-negative, the peptidoglycan layer is in the inner membrane. So for if there is no synthesis of the peptidoglycan layer, then it is not easy for the gram-negative organism to get destroyed. Did you understand why penicillins are best against gram-positive but not against gram-negative? All the peptidoglycan layer is present in both. It is rather protected in gram-negative by another 2 layers outside. Plasma membrane is inside, while there is an outer membrane called as lipopolysaccharide and protein layer, which protects the peptidoglycan layer, which is inhibited by the penicillin in terms of synthesis. Now, basically, mechanism of action is same as penicillin, which I was talking to you about, inhibition of peptidoglycan layer. It covers against gram-positive, gram-negative, but anaerobes also amoxicillin covers, but less than that of penicillin. You can have some atypical infections for which also you can use amoxicillin, which I'm going to talk to you a little later. Now, there are 2 enzymes that would confuse us in practice. One is beta lactamase and penicillinase. Let me tell you, penicillinase is the organism produced by Staphylococcus, which actually makes the penicillin ineffective and destroys it. While beta lactamase is a different type of enzyme, which can be inhibited by clavinic acid, tazobactam or sulbactam. These are potent inhibitors of plasmid-mediated beta lactamases. So, and I was trying to just tell you that sulbactam has got intrinsic activity against Acinetobacter. Indications for most of the beta lactamase inhibitors is that it covers wide range, actually extends the spectrum of the penicillin. Doesn't make it more effective, but makes it extended spectrum. So unless you are thinking of an additional spectrum, there is no need of clavinic acid, tazobactam or sulbactam. Am I clear? Suppose you are thinking of the same spectrum, then amoxicillin alone or penicillin alone is more effective and is better, because it is narrow spectrum and has better efficacy. While I'll also tell you what is this beta lactamase all about. Beta lactamase is an enzyme produced by most of the organisms. It binds to penicillin and degrades it. If you have a beta-lactamase inhibitor, it prevents the binding of penicillin to the beta-lactamase and even reduces the beta-lactamase. And this is the beta-lactam ring which is present in the penicillins. Now I'll go further. There is subtle difference between gram-positive, gram-negative bacteria, and this is important for most of you to understand. While I was telling you that there is an outer layer which is important in gram-positive, there is an inner layer which is important in gram-negative. The inner layer is covered from outer layer by a lipopolysaccharide protein complex in gram-negative. Now in gram-positive, what happens is either there is destruction of the cell wall by synthesis inhibition or otherwise, but even the beta-lactamases are there in the periphery, in the outer membrane. So if you use if you have a beta-lactamase enzyme, then the amoxicillin is rendered ineffective. And if you use an inhibitor, then it doesn't allow the beta-lactamase to bind to the penicillin, and therefore the penicillin destroys the cell wall, or amoxicillin for that matter. Now, in a gram-negative bacteria, the entry of the penicillins is through some pores, and after getting in, they will destroy the inner wall, and therefore you have a complex of beta-lactamase with the penicillin which causes destruction. But remember, if you use a beta-lactamase inhibitor in a gram-negative infection, the point is that the inhibition is not very, very good, simply because that is inside, and even the drug clavulanic acid has to enter inside and then cause inhibition of beta-lactamase. That means to say beta-lactamases are exposed in a gram-positive organism and beta-lactamases are less exposed in a gram-negative organism. That's all I wanted to tell you. There is a small difference which is not so important for you. Suffice for me to tell you that if you use a beta-lactamase inhibitor, it definitely extends the spectrum. Now I'm trying to take you to the next basics, which is very important in respiratory practice, which is of current research and is being talked about more and more, is biofilms. And what are these biofilms? Biofilms are nothing but thin layer of a complex of the mucociliary apparatus and the mucosal outer layer, which is a gel sol layer, and there is a formation of a thick film which is there, which can happen in upper or lower respiratory tract along the mucous membranes. I'll just show you how does that work. Now let's say if there is a cilia here, can you see the cilia? And above that there is a biofilm. This is a thick mucin film. Once it is formed, the organisms can get colonized in biofilms. If the organism gets colonized in the biofilms, they can proliferate in the biofilm. And the drugs don't reach the biofilm. See, drugs pass through the oral or hematogenous route and they reach the epithelial cells. And the drugs can reach up to cilia, but they may or may not reach biofilm very well. I'll just show you further. Now, these are the places in the respiratory tract which will form the biofilms. For example, chronic otitis media in the middle ear, chronic rhinosinusitis, eustachian tube, adenoids, tonsils, bronchiectasis, persistent bacterial bronchitis. These are the diseases in which there is formation of thick slimy layer, and this slimy layer will even prevent the beating of cilia also. So they will not only, this biofilm will work as bio, but it also work as a film which prevents the ciliary motility. And therefore, what you ultimately have, this is how a biofilm would look. And the organisms on top of it, gram-positive organisms. This is electron microscopy of the biofilm that you can see. There those what you see that are cocci, which are nothing but a bacteria. Now I'll just show you a topographic picture of how this biofilm works. Now these are the organisms that gets attached to the mucous membrane, and after attachment they don't adhere to it and they get out. But if there is colonization, microcolony and proliferation, then this is how the biofilm is formed on top, and that will actually prevent the upbeating of cilia as well as they form proliferate in number and create problems. Why I'm talking about biofilm so much is because this will decide the duration of antibiotic therapy and type of antibiotic therapy for you. If you use only amoxicillin when there is formation of biofilm, it may not be that effective. You need clavulanic acid as well, and you need for prolonged periods also. You can't give for 5 days and clear the biofilm. You need to give beyond 5 days or 1 week. You may have to give 3 or 4 weeks of antibiotics to clear all the organisms in the biofilm. This is very, very important concept. I think now you understood why in some diseases like bronchiectasis, you use an antibiotic, but often a broad spectrum antibiotic may or may not work. You continue to get the copious sputum and continue to have the infections. And secondly, you might have also seen protracted bacterial bronchitis, some recurrent or persistent otitis media, which is when you take a course of antibiotics, the ear discharge doesn't stop in a chronic otitis media for obvious reasons of formation of biofilm, and for the same reason, an adenoid will not shrink with antibiotics, and sometimes the tonsillar size remains same in spite of antibiotics. I think I have answered you the clinical application of biofilm, which is very, very important for all of you. Now let's get into some basics with related to adverse effects. Now, what are these reactions following amoxicillin? You will get red rashes. I don't know whether you have observed. Sometimes the palms becomes red, cheeks become red following amoxicillin. Even the eyes can turn red. And often you get confused. These are drug induced. And why this happens? Can anybody put it in the chat box? I'm sorry, but I'll tell you, I can't in a DIP platform, I can't interact with others. So therefore, I will just tell you the answer. It is because of the sulfur molecule that is present. And these are sulfur related adverse reactions that you can get in amoxicillin. The treatment is that you can just stop the drug. If it is severe, if it is minimal, you can just continue the drug while assure the patient. And treatment is not very, very important for us, but we need to recognize them as drug induced. Otherwise, we'll relate it to the pathology. Now, I'll get into the indications for amoxicillin in practice. Now, the respiratory tract is like a highway. Nose, throat, larynx, trachea, bronchi, bronchioles. It's like a highway. You can drive through the tract. That's what the air does. Am I clear? However, there are sideways also in the respiratory tract. Can you tell me what are those sideways? Sideways are nothing but sinuses. Sideways are also middle through the eustachian tube. The dead end is alveoli. So why I need to understand this main road and side road? Along the main road, you don't need antibiotics. You don't need antibiotics for nose. You don't need antibiotics for throat. You don't need antibiotics. Throat, I mean to say nasopharynx, oropharynx. You don't need antibiotics for larynx. You don't need antibiotics for trachea, bronchi, bronchioles also. This is a broad statement. I do understand some academicians can give me exceptions, but let us understand that why we don't need antibiotics is because there is a pan infection of this tract in viral infections. However, in case of bacterial infections, they need to settle. The bacteria gets inhaled. The bacteria has to settle on the microcilia, and then they have to adhere to the epithelium. They have to proliferate. Can this happen in a busy road? Very difficult. Are you understanding? The air currents don't allow. But if you go to the side roads, the air currents, stop there, like within the sinuses, within the eustachian tube, which gets aspirated into mid-layer. There is no difference between a sinus and a mid-layer. Tell me why? Mid-layer is also one of the sinus, connected by eustachian tube. The eustachian tube is a hollow muscular tube. Are you understanding the point? It's just another, it's like a maxillary sinus only. The eustachian tube works like an ostia, but the difference between an ostia of a sinus and that of the eustachian tube is basically hollow muscular tube, and therefore mid-layer infections are guided not by anatomical continuity, but by pressure mechanics. If you cry, if you do Valsalva maneuver, if you do then you will aspirate into the middle ear. Are you getting my point? Positions, the entry of the milk into the or oropharyngeal secretions into the middle ear. So all these things happen because through the eustachian tube, which is guided by pressure mechanics. That's why excessive crying happens in otitis media. Now, suffice for me to tell you that when you get into the side roads, like aspiration into the middle ear or the sinuses, then you will get stasis and infection. And the dead end also has stasis and infection. Therefore, alveoli, parenchymal infections and pneumonias. In tonsils, what happens is there are crypts which work like side roads, and within the tonsil there is crypt abscesses, which are micro abscesses that are formed in the tonsils, that also causes infection. Now, I am telling you so much. Unless you have stasis and infection and adherence of the bacteria, you do not need antibiotics. Dr. Vijay Kumar was asking, kindly tell us what are the indications. The indications for antibiotics are sideways, like otitis media, eustachian catarrh, which can also be viral, but probably they are more likely to cater for bacterial infections. Sinuses, even sinuses can be because of viral infection, but there is always seeding, stasis and infection that happens within the crypts of the tonsils, which is purely because of streptococcus. And then again you have the dead end, that is alveoli, where you have parenchymal infection, which we call popularly as pneumonia. Am I clear on indications for antibiotics in general, amoxicillin in particular, in respiratory tract infections? If you ask me why amoxicillin, amoxicillin is because one of the most important pathogens that affects the respiratory tract is streptococcus pneumoniae, and that affects the middle ear, that affects the pneumonia, that causes lower respiratory tract infection pneumonia, and streptococcus is also a cause of tonsillitis and sinusitis, and therefore you need amoxicillin in all these situations that you are going to use. Now, should I prescribe amoxicillin or amoxiclav? Now, I'll tell you the difference between the two is very much obvious from this slide of which you see. Mechanism of action is both plus, but there is a beta lactamase advantage, inhibition advantage in amoxiclav. The spectrum is broad in clav versus narrow in amoxicillin. The efficacy is same for amoxicillin and amoxiclav, so there is no point in giving more money for clav. But the only two organisms for which you need clav is Moraxella catarrhalis and Staph aureus, because purely for amoxicillin, there could be drug failure related to these two organisms, and best done with clavinic acid. So, can I also tell you that in respiratory tract infections where Staph aureus is more likely, you can give amoxiclav as first line than plain amoxicillin. However, amoxicillin is not contraindicated, but amoxiclav is relatively better, and especially when you have Moraxella catarrhalis, which is a feature of otitis media or sinusitis at times. At times, the clav would be better. So if you add clav, you can add it as either second line drug or primary first line drug in following situations. Now, what next? No, the ratio of amoxicillin to clavinic acid is also important. Suppose you use 1 part of amoxicillin and 1 part of clavinic acid versus 4 parts of amoxicillin, 1 part of clavinic acid. What should be there? Commercial preparations are ranging from amoxicillin 16 times to clavinic acid 1 time to just half of amoxicillin is clavinic acid. So we have wide range of preparations that are available in the market, and which one to choose. See, I will just show you an important study, which I'm not giving you the reference, but I wanted to just focus on the top: H. influenza, H. parainfluenza, H. influenza, strep pneumoniae, Staph aureus, and catarrhalis. If you look at these, if you look at amoxiclav, where amoxicillin is more for the clavinic acid, look at the efficacy against H. influenza and parainfluenza and strep pneumoniae. So when you have more amoxicillin, it is better. You don't need more of clavinic acid. What I also mean that no clavinic acid is also okay for H. influenza, parainfluenza, and strep pneumoniae. But when you have MSSA and catarrhalis, you need clavinic acid more for the given amoxicillin. That means it is rational to add clavinic acid. It is also rational to add more of clavinic acid in these situations for given ratio of amoxicillin. So therefore, whenever you use the drugs, use it judiciously. Okay, I'll make the life simple for you. let me tell you a serious infection. You wanted to use amoxicillin or amoxiclav? That is my question. Okay. Now, if there is a serious infection, is staph likely? If it is staphylococcal likely, then you have to use amoxiclav, then amoxicillin, number one. Number two is that if you have an extended infection, like say catarrhalis is likely, then you need clavulanic acid. Or if you have primary organisms like strep pneumoniae or H. influenzae, then there is no difference between amoxicillin and amoxiclav, and you can fairly use amoxicillin only. Then you can use very less of less of clavulanic acid for the given amoxicillin. Now, in case of skin and superficial infections, you can afford to have more of clavulanic acid, less of amoxicillin. But when you go for serious infections, you should have good amount of amoxicillin, maybe less amount of clavulanic acid. This is a very, very important point. And in severe infections, when you are calculating the dose of amoxicillin or amoxiclav, don't count on the clav. Please count on the dose of amoxicillin. I think I made the point very clear to you. I give one popular drug like augmentin, just focusing on the ratio of amoxicillin to amoxiclav here. Amoxicillin 125 mg, clavulanic acid is 31 mg. So it's almost 4:1 in augmentin. You can have various prescriptions, but whenever you get a bottle, please, or a tablet, please look at the ratio when you are prescribing. We don't think so much when we are prescribing. That's very, very important. Now, consider co-amoxiclav as a second line drug. Now, if you give amoxicillin and there is a failure of amoxicillin, you should use co-amoxiclav. If there's recurrence within 2 weeks, probably there is failure simply because of possibility of resistance, or also because that there is no clearance of complete eradication of infection. And beta-lactamase producing bacteria are likely if there is an exposure within last month for amoxicillin, or if there is associated purulent eye discharge, where alternatives are most likely. And if there is recurrent acute otitis media unresponsive to amoxicillin, you should use co-amoxiclav. I think I made this point very clear to you as far as amoxicillin versus amoxiclav and the ratio and which one should be prescribed and why. Now let's look at some of the preparations that are there in the market that are available. Now you have got syrup, you have got tablet, but remember that whenever you're using amoxiclav, they turn brown in color if you don't store it properly in the refrigerator. Only for 24 hours it retains the color. After 24 hours it becomes brown and is ineffective. And same is the story with injectables also. So safer is to use capsules or tablets or dispersible tablets, because the storage properties are better. And syrups, dry syrups are also not as good as dispersible tablets because we reconstitute them. And in our developing country like ours, you remember they don't fill up to the mark. Sometimes they fill the full bottle. I have the experiences where the mother has taken 1 spoon of the dry powder, 1 spoon of water, and she has mixed and given. So various things do happen in practice. So therefore, my dear friends, don't go for the bottles, PET bottles. This is my humble request. And tell me, what is the strength of the most of the bottles? Is it 60 ml or 30 ml? Popular. Most popularly 30 ml, because pharma has a commercial mind. They reduce it to 30 ml and cost you more. And 30 ml means 5 ml twice daily, will not come for 3 days. And there are no 3 days of amoxicillin indications. If you want to use an upper respiratory tract infections, you have to use for 10 days. And you have to buy 3 bottles. Tell me the name of the mother in your practice who has used 3 bottles. Do you agree? So therefore, my dear friends, once the fever goes down, they will stop antibiotics. So therefore, my dear friends, prescribe dispersible tablets, educate them. And dispersible tablets at least come 10 tablets per strip. And you can fairly tell them to give for at least 5 days in most of the infections. Now let's look at the dose and duration. This is very, very important. How much of amoxicillin to be used? I wanted to just take you through some basics. You need to understand the difference between penicillins versus aminoglycoside, or cephalosporins versus aminoglycoside, amoxicillin versus aminoglycoside. Very, very important. There is something called as minimum inhibitory concentration of the drug, above which only the drug is effective. Below that, the subclinical doses, they don't work, or the organism is not inhibited. Only when your drug dosages go above the level of MIC, you know the drug is rendered effective. Now look at the amoxicillin. Now it is amoxicillin efficacy depends on how long the amoxicillin is levels are above MIC. How long? Time dependent. The killing is time dependent, not peak dependent. It is time dependent. Am I clear? So therefore, you should see that amoxicillin is given frequently, or a cephalosporin is given frequently, or a penicillin is repeatedly given in such a way that most of the times in a day, the amoxicillin or penicillin is above MIC. You can't give one full dose, one dose, and assume or dream that most of the time the drug is above that level. So therefore, my dear friends, you may have to repeat the doses of cephalosporin. While in contrast, aminoglycoside is concentration dependent, not time dependent. You just need to have the highest mountain peak, Cmax, maximum concentration you have to reach. And therefore, more the concentration, more is the killing. In amoxicillin, more the duration, more is the killing. Whereas in aminoglycoside, more the dose, more is the killing. Am I clear? Now, if you use more doses, what does that mean? In aminoglycoside, you need loading doses. That is because Cmax achieved is earlier and faster and better. It acts fast. And most of the times, aminoglycosides are indicated in severe infections, not as the first line drug, and therefore you have to achieve Cmax fast and you give a loading dose. Do I need to give aminoglycoside more frequently, or once a day is enough? Once a day is enough, because the peak decides the killing, not the duration of the drug in terms of pharmacokinetics, duration of action. And therefore, my dear friends, if you combine penicillin or amoxicillin with an aminoglycoside, there is synergy, because one kills at the peak, another kills through. Therefore, you are going to have synergetic action. So this is the debate about frequency versus dose, and dose versus duration. My dear friends, let's look at some of the indications and the duration of antibiotics. I told you the duration depends on whether there is formation of biofilm, whether there is reason required for eradication of bacteria. In upper respiratory tract, like otitis media, sinusitis, there is anatomical complexity of those structures, and MIC achieved is less, biofilms are formed, and therefore we need to give for longer duration, like 10 days, 14 days, 15 days, 3 weeks, 4 weeks, like that. In community acquired pneumonia, it's a spongy structure, and vascularity is good, and therefore you can just give for 5 or 7 days, which is more than enough. And I'll come to break up on the duration further. Now, there are trials that are done in community acquired pneumonia. There is SCOUT CAP trial, which compared 5 days of antibiotics versus 10 days of antibiotics, found that there is no difference between 5 and 10 days. Then why give 10 days? Give only 5 days. There is another trial called SAFER trial, which compared 5 days versus 10 days of amoxicillin in community acquired pneumonia, which said that they are comparable, and therefore why give 10 days? Let's give only 5 days. There is a beautiful article which all of you can refer, published in 2021 in JAMA, and less is more for amoxicillin. You don't have to give 90 milligram per kg. You can just give 40 milligram per kg, and for a shorter duration, still it works for us, because we have intermediate resistance for penicillin in the community, and you need not worry. This is an excellent trial. This is the only trial that compared both dose and duration of amoxicillin in community acquired pneumonia, and these are the results. Now, how do we analyze the results of a trial? I'll take you through a little bit of difficult slides, but do not worry much about if you need antibiotic retreatment in children after they have received oral amoxicillin, that means that is considered as a failure. You understand? Now, when you give 30 to 50 milligram per kilo of amoxicillin, 12.6% required retreatment. Whereas when you use 90 milligram per kilo, only 12.4% required retreatment. That means to say, whether you use 50 milligram per kilo or 90 milligram per kilo, the chances of antibiotic retreatment is same. 12.4%. 5%, which means that why give 90 milligram per kilo? Give only 50 milligram per kilo. This is in community acquired pneumonia. I'm not talking about otitis media, because in otitis media sometimes MIC required is could be MIC achieved in the pus in the middle ear may be low. You may need 90 milligram per kilo. But here in community acquired pneumonia, there is no point logic in giving 90 milligram per kilo. So 50 milligram per kilo is enough from this trial. Now, for patient receiving 3 or 7 days, the retreatment or treatment failure is again 12.5%, which means that you can give as low as 3 days in community acquired pneumonia, same as 7 days or 10 days. There's no point in giving for 7 days, 10 days, etc. Now, can I give only for 3 days in community acquired pneumonia? Now, because of the expected mortality, and we are giving oral amoxicillin as the first line of drug, we will not be, at least we will not be confident for you to just stop at 3 days. We'll give it for 5 days. Definitely not necessary for 7 or 10 days of therapy. Am I also clear on the duration of amoxicillin that is required for community acquired pneumonia? There is no difference between injectable amoxicillin and oral amoxicillin because absorption is fine in both, provided there are relative contraindications like childish sensorium is not good, not able to take orally, there's vomiting, etc. But for these reasons, you can fairly give orally also. There's an excellent trial from Lahore, which was done from Pakistan, which I loved that, and WHO adopted it. Even in severe pneumonias, you can give amoxicillin orally and save the patient's life. This is simply because that trial showed that even in children with chest retractions, you can use amoxicillin orally. Now, 5 days versus 10 days, the cure rate is same. So you can give for 5 days in amoxicillin. So this, I think I told you, the various books and references which give you various doses of amoxicillin, starting from 25 milligram per kg to 100 milligram per kg. You have various references. Do not get confused. Please decide. If you are dealing with severe infections, you don't take the risk of giving 40 milligram per kilo. You can go up to 90 milligram per kilo. Non-severe infections, you can always manage in our country with 40 to 50 milligram per kilo of amoxicillin. Now, how to decide whether I should give 90 milligram per kilo or 50 to 60 milligram per kilo in cases of community acquired pneumonia? This is best. When there are no risk factors, you can just give 60 milligram per kilo. When the risk factors are present and when there are severe infection, you can go to 90 milligram per kilo. What do you mean by risk factors? Let us say comorbid condition, liver disease, or nephrotic syndrome, or you say immunosuppression, or you can say malnutrition. Are you getting my point? So in all these situations, please do not risk with 60 milligram per kilo. You can go for 90 milligram per kilo. But otherwise, in day-to-day management, you can use amoxicillin 40 to 60 milligram per kilo. Now, how do we give? 2 doses or 3 doses? I told you amoxicillin actually requires 3 doses, but it's 2 doses are sufficient because there is some hangover effect in amoxicillin. Following its duration of action also, there is a post effect, effect bactericidal action that is very much there in amoxicillin, and therefore there is continued killing. Let's say you give for 3 days amoxicillin, there is continued killing even on the 4th day. So this effect which is there in amoxicillin is an advantage for us, and therefore from 3 times a day we have made twice daily, and there are trials with once a day amoxicillin also. Now therefore, suffice for me to say that if you are looking at streptococcal infection and tonsillitis, let's say, and I want to give for 10 days, tell me, should I give 3 times a day for 10 days or once a day for 10 days? Who will take 3 times a day for 10 days? 30 times? Nobody will take. Compliance will get affected. Then smartly I will make it once a day for 10 days. Suppose if I have to give twice daily, then 5 days. If I have to give 5 days, then I will give twice daily. It makes it convenient for me. If I have to give only 3 days, then I can give 3 times a day for 3 days. So this is how I would titrate the frequency and dose of amoxicillin. If there are questions, I will further clarify it for you. How do I give the amoxicillin? Please tell me how many of you have taken amoxicillin. Now the problem with amoxicillin is is that syrups, the doses are horrible, the way they give in our country. I do agree, you can always question me, you know your patients better, but I prefer to give dispersible tablets of amoxicillin. And talk to the mother, talk to the child, discuss about the taste. Amoxiclav is bad in taste. Amoxicillin is good in taste. The tablets of amoxicillin are cheaper. Don't tell me, sir, if I prescribe amoxicillin syrup, they will pharmacist will give amoxiclav. Whereas tablets that cannot give amoxiclav tablets to a child. Dispersible tablets are therefore a substitute which I have discovered in my practice that makes the pharmacist to give only amoxicillin but not amoxiclav when I want amoxicillin. This is only about amoxicillin in detail. In the next sessions, I will be covering some of the other antibiotics which you want. Maybe if you want ceftriaxone, or maybe if you want doxycycline, if you want azithromycin, if you want quinolines like levofloxacin respiratory practice. I will deal with you in subsequent sessions. And that's it from my side. I would look for some questions from you. Greetings from my side and wish you happy amoxicillin days, while keep a guard on stewardship, that you don't need measured the times drugs, because most of the times you are in the highways, not in the sideways. That provided you have done a good clinical examination and diagnosis, your stewardship for antibiotics will continue. Can I give in respiratory infections? The myth of secondary bacterial infection is not a reality. So diagnose and then treat. Now, can I give steroids with antibiotics? Steroids are not useful in polymorph nuclear infections with leukocytosis, because it is not anti-neutrophilic. It reduces the neutrophil count over days, but it is anti-neutrophilic, less than what it is anti-eosinophilic. If you have an eosinophilic inflammation, you should use steroids. If you have a neutrophilic inflammation, you should not use steroids, because it is not that effective as much as you would expect in eosinophilic inflammation. Steroids therefore are very effective in anaphylaxis. They're very good in type 1 hypersensitivity reactions. They are good in asthma, non-infectious diseases, parasitic infestations, which are with eosinophilic inflammations. Whereas with neutrophilic inflammations, steroids are not helpful. I addressed that query from Dr. Vijay Kumar. I hope that I have addressed most of the indications, the way to use amoxicillin, the way to combine with clavinic acid, how to prescribe, how much to give, and the controversies related to it, evidences from the studies, and how you can be effective as a practitioner when not to use amoxicillin and when to use amoxicillin. Although it looks very simple drug, the problem is that it is the most commonly available drug for your pen and practice, and therefore use it judiciously and use it properly. And I will hand it over back to Dr. Vijay Kumar, Dr. Ramkrishna, and Dr. Bajania. And if there are questions, I'm happy to take.
And as usual, sir, Subramania sir, this lecture has been like an expert clinical pharmacologist giving the principles, the complex pharmacology principles made very easy, sir. You have covered, I think you have covered every point that I was expecting, and probably all of the audience are expecting, sir. You have covered the basic difference between amoxicillin and amoxiclav, and the advantages they have, and then the science behind the duration of selection of antibiotic therapy. And in your entire lecture, you have used the upper respiratory infection only once, and all the time you were using the specific diagnosis of adenoiditis, rhinosinusitis, pharyngitis, and this actually helps us a lot than selling URTA and LRTA. Frankly, to decide an antibiotic or not, to decide which antibiotic, most of our patients probably would be with this amoxicillin and maximum amoxiclav. So this diagnosis of URTA you have not used at all, sir. Thank you very much for using all these specific diagnosis, which can be a pure clinical diagnosis, sir. And you have also given the ratio of clavulanic acid and amoxicillin, which is very useful for us to see now that what are all the brands that we write in our daily practice, and to decide which brand is good for the given patient. We have also given the complex of the time dependent and peak dependent and concentration dependent, and why aminoglycoside is good as a single dose, 2 dose, 3 dose that you have given very well. And I think I have in the chat box. I am not seeing any questions, sir. I think Ramakrishna sir.
Now the DIP will have some questions. I think they should transfer it. Chat box is only for the faculties.
Yes.
Chita, if there are any questions, you can type them.
Sir, I have a question.
Please.
Amoxicillin or amoxiclav, can it be given? What is the role in typhoid? Approved lab proven typhoid.
If you are using amoxicillin or amoxiclav, it doesn't make much difference as far as choosing clav versus amoxicillin in infections, but definitely amoxicillin itself has good gram-negative coverage. Only what I had to read Vijay Kumar sir, the basic pharmacology book before I prepared this lecture. I'm not going by the epidemiology in India, Salmonella resistance, which you will know better in your areas. But coming to the basics of pharmacology, except when you go for Pseudomonas, down the line, E. coli and Salmonella infections, amoxicillin and amoxiclav are equally effective. There is no problem because it is amoxicillin of amoxiclav that works. Now, I will be wondering if you are using amoxiclav in typhoid, please be careful that you use less clav and more amoxicillin, because it gives a pseudo feeling that you have given more doses when you use more clav. Please be careful. I think I made that point very clear. However, when you are using skin and soft tissue infections, don't worry much, because even if there is a little more of clavulanic acid, it's okay for me, because you are dealing with staphylococcal infections generally. I'm generalizing it. I'm sorry for oversimplification, but in that case, you know, you definitely need, because amoxicillin is little poor for skin infections, you need amoxiclav. I don't mind using more of clav, but less of amoxicillin, because for skin infections, even 20 milligram per kg of amoxicillin is also enough. Even if you have 1:2, it's okay for a skin infection. What I meant was your commercially available preparation if it is cheap. But if you are using for serious infection, the amoxicillin should be more for the given clavulanic acid. Very, very important. The killer is not clavulanic acid. The killer is amoxicillin. Please let us understand. If you need less killer, then use less of amoxicillin. You can use clavulanic acid as a complementary thing. Whether you need clavulanic acid or not depends on whether you are contemplating a staphylococcal infection or Moraxella catarrhalis. Is that okay, sir?
Yes.
Clarity comes, because this is the most important message which everybody wants to know. And you might be wondering why I have chosen this topic, because I felt that there are many topics which we listen and that doesn't make difference in our practice. Because this is something which we write daily and we do not know. I happened to meet a colleague of mine, friend of mine in Bangalore, in one of the CMEs. When we were having tea or coffee, he told, sir, you people are faculties, tell so many things, but you please tell me top 10 drugs that we prescribe in practice in your CMEs. This was one of the top 10 that I have used. Because it's very, very important, because we know less of what we write frequently. We know more of a syndrome that we see rarely. And it's very, very important to know in depth. I request the audience, the drugs like, let's say, Lasix, the drugs like amoxicillin, the drugs like ceftriaxone, the drugs like ciprofloxacin, or whatever, you can take aminoglycamic acid. Please read them more, because you do prescribe them day in and day out. You should know every inch of it. If you do not know the drug, which is rarely being used, let us say monoclonal antibodies or some other drug, I will tell you, thank you very much, no problem. Even if you ask me, I don't know. When I have to prescribe, I'll open up my books, I will not give just because of I remember the dose. Even though I remember the dose, I don't go by that. I'll open the book, see properly. There's enough time, read one page, and then tell your residents or yourself go and prescribe. Please do not be very humble. There is no shame in front of the patients. Also, you can open the book and tell them this is 35,000 rupees one vial for cholesterol. If you want to give, it's very expensive. You go back and read it. You don't have to buy hard the doses. But there is no excuse if somebody doesn't know ceftriaxone and amoxicillin in detail. That was the main crux of the matter why I took amoxicillin. It looked like a childish way of looking at it, but I felt that the drug which you prescribe day in and day out, you must know everything about it. In fact, I should thank that friend of mine who made me read complete amoxicillin because he made me read the whole pharmacology book of amoxicillin. Sir, over to you. Back to you. Ramesh, you can have a couple of comments.
Yes, sir. I mean, I was just listening. It was spellbound. You covered each and everything in such a meticulous way that hardly audience has any question. Most important thing is the selection of this topic, because I personally many times at many sessions I say this, that you concentrate more on common things. Uncommon things are uncommon. Common things are common. Like if we look at our practice, then our bread and butter is respiratory tract infection. Most common prescribed medicine is amoxicillin. And the way in which you covered amoxicillin, I mean, it was more of a as pharmacologist. This reminds me of a very funny and a very unique incident during my postgraduate MBBS days. Every batch has a student who is generally from morning to evening. His main intention is to depress the colleagues by I mean, every batch has such type of students. Right now he's at US. So every day morning in mess, he will bring out some syndrome. And I don't know from where he knew that there are some 1200 plus syndromes. So when we were struggling to understand even simple topic in morning while having breakfast, he will mention one syndrome. So in our PG clinic, Dr. Jain Patel, he was recently passed away, but he had a great sense of humor. So he told this student, I won't name him, he told him that I personally feel that this time the gold medal belongs to you. The way in which you know the medicine, I am very sure that the gold medal belongs to you. But if you pass,
That's a
so,
nice.
so since then, I always feel that a common pediatrician should be well aware of common problems and common medicine. So my very heartily congratulations to team Andhra for covering this, but for keeping this topic, and congratulations, Subbu. Sir, you have covered it so nicely that hardly anyone has question. Thank you so much. Thank you.
Ramakrishna, sir.
Right. Thank you, Dr. Subramanya. You have done it excellently, as usual, of course. I'm the happiest person when you have selected the topic, amoxicillin in respiratory practice, because I'm the strongest authority to prescribe appropriate medicine, appropriate antibiotic, even though it looks very simple, not fancied, not adopted by many people. In the process, I always tell the postgraduates, amoxicillin is a golden molecule which we are not using, or the pharma is not allowing to use, even though you have that awareness, because amoxicillin is very difficult to get, at least majority of the places, for the reason of their business. And it's a golden molecule, and Dr. Subramanya made us aware how it is much more than golden molecule by dealing its basics, pharmacology, pharmacotherapeutics, the way, mechanism of action, and clinical applications in a nice way, in a most understandable way. And it's very refreshing to hear from Dr. Subramanya, from his DM clinics to striking to the most important and commonly used antibiotic. And I tell you, it's a great service that Subramanya for the patients for in advocating the appropriate use of antibiotics and AAA, that is avoiding antibiotic abuse. And from now on, I expect people to think of amoxicillin first, then only going for next step. And Dr. Subramanya, I have a question for you.
Please.
Adenovirus infections, respiratory infection, they mimic bacterial infections.
Okay.
In such case, would you like to go for amoxicillin? Because we cannot differentiate adenoviral respiratory infections in the initial 3-4 days, 5 days. So
Okay.
what's your take on that?
Sir, can I
I know
answer?
viral infections we should not be
Very
used,
difficult.
but
No, I-
adenovirus is an exception where it may present like a bacterial infection in many
Very
ways.
difficult for me to give evidence-based medicine answer. Sir, permit me to give my personal opinion on this because
Yes.
very difficult. Evidence-based medicine says that you diagnose and then give, you isolate and then give, or you do PCR and then give. Let's forget that for a while. What will I do if I'm sitting in a clinic? Now, if I have an epidemic situation, then I will not give.
Of course.
If it is endemic, then it is very difficult to differentiate. Now I have only two choices when it is endemic infection of adenovirus. I will go by the severity of infection. Can an antibiotic be given after 24 hours? This is my first question. If answer is no, even if it is a severe adenoviral infection, then I will end up giving amoxicillin. Let me be honest. Because in a severe infection, there is no point in rationalizing too much for us, provided it's a straightforward diagnosis. I'm not talking of straightforward diagnosis. Sir. Straightforward bronchiolitis, please treat bronchiolitis. Straightforward group, you treat group. I'm not coming to that point. Suppose you are not able to diagnose because children don't walk with textbook descriptions. In those situations, I'm talking. In these situations, if there is an endemic situation, not epidemic situation, not in crops, but occasionally one case comes, I have a doubt whether it is adenovirus or not. And the patient is also severe in terms of infection severity. That does not allow me to rationalize and doesn't give me time. Or if I wait, then it could be ethically detrimental and outcome could be affected. Then definitely I will err on giving first dose of antibiotic, because till date, our deaths from pneumonia are not less. They are quite high in our country. After our reduction of mortality from community-acquired pneumonia reduces to a very low level, then we can go for rationalizing like in the West. Suppose the infection is non-severe, then I will review after 24 hours. After review of 24 hours, again the question is, now it is non-severe or severe. If it is worsening, then I will come back to the first answer that I have given. If it is non-severe, I will review after 24 hours. All that we need to do is that, I don't know, can I share with you one experience of mine? 3-month-old baby was admitted with lower respiratory tract wheeze and respiratory distress and fever. And in 3 months, the dilemma is whether it is bronchiolitis or community-acquired pneumonia. Definitely. But when I cleared the nose, gave paracetamol and oxygen, the baby became better, started crying well and started feeding. Respiratory rate was around 45-50. Let me tell you, pulse ox was normal. I'm giving you the debate between mild bronchiolitis versus early community acquired pneumonia. You understand, no? Very, very difficult. But then the wheezes and syndrome doesn't appear in pneumonia, whereas the lower tract disease is obvious in absence of wheeze and upper respiratory catarrh in case of community acquired pneumonia, which we know. This is theoretical, but on a line, if your child doesn't get stabilized and the toxicity does not come down, the child continues to appear sick in spite of stabilization of giving paracetamol, nose clearance, and hydration, then you give the antibiotic. If your child starts playing, crying, becomes hungry, becomes lively after giving supportive therapy, then you don't require the dose of antibiotics, probably it's viral. I think I've answered in two styles. of whether it is a viral infection or a bacterial infection. Adenovirus from the point of view of epidemiology and epidemic and pandemic nature of it versus endemic, and also how I would differentiate in my practice viral versus bacterial. I think Ramakrishna sir, I have
Yes,
narrowed down. Of course, one cannot be purist by telling that I will be able to finally clear on that. Suppose if I have if I have to err in developing country like ours, I will err on giving an antibiotic, because if I've given so much of thought, then it is better to give. What we meant by irrational practice is don't even think. After paracetamol, my pen writes down amoxicillin and azithromycin. That's wrong. You know, don't even think of anything. Polio drops plus amoxicillin. You know, it doesn't make any sense. Somebody has gorgora, you give polio drops and also say you take amoxicillin if it worsens tomorrow. These kind of practices can be comfortably stopped. If you are at spinal level, do not give amoxicillin. If your cortex comes to work, you can give amoxicillin. I think spinal level prescription of amoxicillin is irrational. Cortical level prescription of amoxicillin is fantastic and is acceptable. I'm sorry for making that reflexly writing versus giving a thought and then prescribing. In that case, suppose you err, it's all right. You have done a wrong thing. No time when you think, every time you think you can do the right thing, the answer is no. I'm not philosophical, but I'm very practical in this. Vijay Kumar and Ramesh, do you agree with this? It makes sense.
Absolutely, sir.
Absolutely.
Sir, one question if I have time.
Yeah,
Yes,
please.
sir. Carry on.
Sir, in practice, sir, for the topic that for last 1 hour you have covered, one question, sir.
Please.
A ENT surgeon asks the pediatrician to give fitness for a tonsillectomy or adenoidectomy, or otherwise the other thing, when a pediatrician in this setting should send to an ENT surgeon for tonsillectomy, adenoidectomy.
Okay. I will come to the following issues. If ENT surgeon writes adenotonsillitis or advises adenotonsillectomy, what should I do when it comes to me for second opinion, or if I am the first person, whether I should refer to an ENT surgeon for adenotonsillectomy?
Exactly.
Both I'll answer. But let me tell you a few statements with regard to adenoids. Adenoids is a consequence of submucosal hypertrophy of the lymphoid following continued irritation of the mucosa because of infected material pouring on the mucosa, like a postnasal drip. Often the cause is rhinosinusitis with postnasal drip continuously tickling on the mucosa, and submucosal response is a lymphoid hypertrophy, and that goes in a polypoidal manner and becomes adenoids. I have to explain you this. Will it respond to antibiotics? Like I said, this is where biofilm is formed. 5 days, 10 days of amoxicillin doesn't work for you. So there is no point in giving antibiotics or conservative management for adenoids. The question whether I should treat adenoids, can I treat adenoids by medical ways, conservative ways? I have got an adenoiditis, adenoidal hypertrophy. Should I manage conservatively? The very fact that it is chronic takes away most of the desperate acute things that I do, like giving an antibiotic. This is put away, number one. The rare exception is acute adenoiditis. Let us not debate about it for a while. Most commonly what we see in practice is chronic adenoidal polypoidal hypertrophy. Now, when you have a chronic hypertrophy, the issue is whether it is causing respiratory obstruction or not. That decides the surgery, but not the very presence of adenoids, number one. Number two, how do I know the severity of obstruction? There are two ways of doing. If you want to go by evidence-based medicine, do a nasal endoscopy. There is grading of obstruction, grade 1, grade 2, grade 3, grade 4. Grade 3 and 4 you operate, grade 1 and 2 you conserve. It is not the size of adenoids that is important in a lateral neck X-ray. It is the size of the air space left after adenoids that is important. Am I clear? Suppose adenoids is enlarged, but the air column, you don't see the adenoids, you see the air column. If air column is good, That means he is able to breathe, even if the adenoid size is more. That's what happens when you see a big tonsil, but yet the child is not having many symptoms. It is not the size. I'll give the example. If you look at the snake and a rat, you will wonder whether the small snake can swallow a big rat. It can swallow. That's what I meant by big tonsils or adenoids for a given snake, which is comparable to an airway. It is dynamic but not static. And X-ray evaluation is static but not dynamic. If you need a dynamic evaluation, you should go for polysomnography for respiratory obstruction or sleep apneas, which is golden but not available every time. So therefore, what I do in practice, if I don't have polysomnography available, which is ideal, if you snore during colds, it is normal. If you snore when you don't have colds, it is abnormal. You snore more during colds than otherwise, definitely you are abnormal. If you snore when you are not having colds, please go for polysomnography. If you snore while only having colds, ignore for a while if you don't have the luxury of polysomnography. If you have snore apart from colds, and if there is a growth failure and if there is adenoid phases, please go ahead for adenoidectomy. Don't go for tonsillectomy, go for adenoidectomy. When you go for adenoidectomy, studies have shown that you should not remove only one part of the Walde's ring, because the oropharyngeal infection spectrum extends from adenoids to tonsils. The studies have shown that you have to remove tonsils along with the adenoids. You can't do isolated adenoidectomy and leave the tonsils, because you are leaving 3/4 of the Walde's ring. Am I clear? So you have to remove the entire ring, which is causing the obstruction, and that makes sense. So there is no isolated tonsillectomy or isolated adenoidectomy. One goes above the other. Suppose I'm a pediatrician, if the indications are pointing to adenoids but not tonsils, I will err on the side of the surgery. While if the indications are pointing to more of tonsils than adenoids, I will contradict the ENT surgeon and go ahead with conservative management, because I know for tonsillitis there is only one organism and not many organisms, that is Streptococcus. That is because there was interesting study from St. John's. Kindly permit me to just tell you only one line. There was swabs that have been taken from surface of the tonsils versus culture from the crypts of the tonsils. The crypts of the tonsils showed strep pneumoniae, whereas the surface showed colonization of the oropharyngeal flora. So do not treat the flora, but treat the crypts in the tonsils, which forms the micro abscesses and for which you need antibiotics. That's why the tonsils are enlarged, not only enlarged, they're tender in acute. In chronic, there is a lymphoid response to it, which can be polypoidal hypertrophy. It can be fibrosis causing microtonsils or absence of tonsils, or it can cause firm tonsils. All these things can happen in chronic tonsillitis. I'm not talking of acute tonsillitis, which can also may not be cleared by course of antibiotics. As explained by me, chronicity is because of biofilm, resistance to antibiotics, or curative. So if you want to remove the pocket of infection in adenoids and tonsils, go for adenotonsillectomy. If you want to clear the airway passage, go for adenoidectomy plus tonsillectomy. I think I have answered it. Vijay Kumar sir, is it okay?
Yeah. Yes, sir.
I
Excellent.
can
Sir.
go on for another 15 minutes, but why adenoids, tonsils, pathophysiology, how does that happen, and why you should do surgery versus not surgery. But ask the ENT surgeon to give the grades of tonsils and grades of adenoids. Grading. Now, the last answer, please, you did not ask that question. In allergic obstruction of the airways and snoring, when there is adenoidal hypertrophy, can I use intranasal steroids to shrink the adenoids? This is a very common question asked in most of the practices. If you have significant adenoidal enlargement, if you use steroids, intranasal steroids, adenoids do shrink, but 80% of the times when you stop steroids, the size comes back. You are lucky only 20% of the times to conservatively manage an adenoid following allergic rhinitis. I think I answered role of antibiotics, role of steroids in upper airway adenotonsillitis, chronic and acute.
Thank you.
Any other questions? If there are no questions.
Nothing special. Dr. Ramesh? Dr. Ramesh? Yes.
Yes, sir. The way in which
Go on.
Subbu sir narrated everything, I don't think that anyone has question. Excellent. Nothing more to it.
Right, sir. If there are no questions, shall we wind up the session?
Yeah.
Right.
The last question which was asked to me in one of the CMEs, but I will tell you the answer. Whether in a hospitalized patient, should I use amoxicillin or ceftriaxone? This is a very common question. Do you all agree? This is a very important dilemma that we face. And there was one study which I'll share with you if you message to me on my WhatsApp that says that in hospitalized patients with severe pneumonia, ceftriaxone is better than amoxicillin. Please remember this. We should not hesitate to use an antibiotic when it is required, like ceftriaxone, just because I love amoxicillin.
Especially young
But
child.
however, irrationally prescribing this should be highly avoided.
Yeah.
I think that was an important dilemma one get in practice. I think we will choose these common topics in future and we'll go for the CMEs continue. This makes sense because whatever we discuss will become very, very relevant for most of us in day-to-day practice. Sir, over to Dr. Ramakrishna sir for final comments.
Right, sir. They have made everything very clear and hope most of us will increase our support to amoxicillin in place of the crazy latest antibiotics. Then only the purpose of Dr. Subramania's effort of more than 1.5 hours is it serves the purpose. Right, sir? Thank you, Dr. Subramania, for enlightening us, Dr. Vijay Kumar for moderating the session, Ramesh Bajania, the gentleman pediatrician, for chairing the session and participating in the discussion. Thank you. One and all. We'll close the session. Good night.
Good night.
Good night. Sir.
Good night.
Good night, sir.
Very good.
Bye bye, sir.
Yes, sir. Good night, sir. Thank you so much for this.
Good night, Ramesh. It was nice interacting with you.
Vijay Kumar, my regards. Subramaniam, you are excellent. As
No.
always.
Yeah, I'm your dear
I
friend.
will
Yeah.
always delight to listen to you. Thank you so
No.
much.
That's what is your love. But
Thank
I wanted to read something which is basic from MBBS days than MD days. You know, we
No,
don't.
sir,
read
this is the
basic.
most important medicine. I say that it is the number one medicine which we prescribe during our lifetime. So we must concentrate on common topics.
So next time I will take ceftriaxone. Will it make sense?
Great, sir.
Definitely.
Great, sir.
Because how
Great,
it
sir.
should be injected, infusion, straight, mixed. So many doubts are there with many people.
And take care that when ceftriaxone should not be used. That's it.
That's fine. Rationality is one part, but there is irrationality in irrationality also. That is very bad. You
Yes,
give,
sir.
but you don't know whether you have given. That's the worst thing.
Thank you so much. Thank you, Vijay. Thank you.
Sir, when you take the ceftriaxone topic, please
Uh-huh.
compare ampicillin, amikacin combination to ceftriaxone, sir, in a
Okay,
clinical setting.
done. That's
Yes,
a good,
yes, sir. Yes, sir.
good comparison.
Yes,
Thank
sir.
you.
Thank you very
Bye.
much, sir. Thank you, sir. Sir.